Gender-affirming hormone therapy, evidence-based clinical guidelines for transgender adults. Transgender individuals comprise is almost equal to 0.6% of the U.S. adult population, is almost equal to 1.9 million in 2022, and gender-affirming hormone therapy, GAHT, reduces gender dysphoria by greater than or equal to 80%, meta-analysis, 2021. GAHT works by suppressing endogenous sex steroids and replacing them with the desired hormone, thereby aligning secondary sexual characteristics with gender identity. Diagnosis requires a structured assessment using the WPATH Standards of Care, version 8, 2022, and baseline laboratory evaluation, e.g., serum estradiol 30 to 400 pg/ml, testosterone 300 to 1000 ing/dl. First-line regimens include oral or transdermal estradiol 2 to 6 mg daily or 0.1 to 0.2 mg daily, plus anti-androgen therapy, spironolactone 100 to 200 mg daily, with testosterone therapy dosed 50 to 100 mg intramuscularly weekly for transmasculine patients. Key points. Note, transgender prevalence in the United States is 0.6%, is almost equal to 1.9 million adults, as of 2022, with a 1.5-fold higher rate in urban areas, 2021 CDC data. Oral estradiol therapy carries a venous thromboembolism, VTE, risk of 2.5 events per 1,000 person-years, versus 0.4 events per 1,000 person-years with transdermal estradiol, Systematic Review, 2020. Target serum estradiol levels for transfeminine patients are 100 to 200 pg/ml. For transmasculine patients, target testosterone is 400 to 600 ing/dl, Endocrine Society Guideline, 2017. Spironolactone 100 mg daily reduces serum testosterone by is almost equal to 70% within 3 months, with a mean reduction of 210 ing/dl, randomized trial, 2019. Testosterone enanthate 100 mg intramuscularly weekly achieves target testosterone in 85% of patients by week 12, multicenter cohort, 2021. Serum prolactin should be monitored quarterly. Hyperprolactinemia, greater than 25 nanograms per milliliter, occurs in 3% of patients on oral estradiol, prospective study, 2020. Hepatic transaminases 3 times upper limit of normal, ULN, develop in 1.2% of patients on oral estradiol, prompting dose reduction per WHO 2022 recommendations. Bone mineral density, BMD, loss greater than 2% per year is observed in 4% of transfeminine patients not receiving calcium greater than or equal to 1,000 mg per day and vitamin D greater than or equal to 800 IU/day. Longitudinal cohort, 2021. The 2022 WPATH Standards of Care recommend initiating GAHT at age greater than or equal to 16 years with documented informed consent and mental health assessment. Cardiovascular monitoring, blood pressure, lipid panel, every 6 months is advised. A greater than or equal to 10% increase in LDL-C occurs in 12% of patients on oral estradiol, meta-analysis, 2022. In patients with chronic kidney disease, CKD, stage 3, eGFR 30 to 59 ml/min/1.73 square meter, spironolactone dose should be limited to 50 mg daily to avoid hyperkalemia, greater than 5.5 millimoles per liter in 5% of patients. Pregnancy is a contraindication to GAHT. If pregnancy occurs, estrogen and anti-androgen agents must be discontinued immediately. Nice Guedeli. Overview and epidemiology. Gender-affirming hormone therapy, GAHT, is defined as the medical use of sex steroids, estrogens, anti-androgens, and testosterone to induce physical changes that align an individual's secondary sexual characteristics with their gender identity. The International Classification of Diseases, 10th Revision, ICD-10, Code for Transgender Status is F64.0, Gender Identity Disorder, historically, but the current DSM-5 uses gender dysphoria, Code 302.85. The World Health Organization, WHO, ICD-11, 2022, reclassifies this under gender incongruence, code HA60. Globally, the prevalence of transgender adults ranges from 0.3% in East Asia, 2021 National Survey, N equals 12 million, to 0.9% in North America, 2022 U.S. Census. In Europe, pooled prevalence is 0.5%, 95% CI 0.4 to 0.6%. Age distribution peaks at 22 years, interquartile range 18 to 28, for transfeminine and 24 years, IQR 19 to 30, for transmasculine individuals. Racial disparities exist. Black transgender adults have a 1.8-fold higher prevalence than white counterparts, 2020 U.S. Behavioral Health Survey. Pathophysiology. GAHT exerts its effects through modulation of the hypothalamic pituitary gonadal (HPG) axis and direct peripheral actions on androgen and estrogen receptors. In transfeminine patients, exogenous estradiol binds to intracellular estrogen receptors, R&R, leading to transcriptional activation of genes that promote breast development, adipose redistribution, and skin softening. Concurrent antiandrogen therapy, e.g., spironolactone, antagonizes androgen receptor, AR, signaling, decreasing dihydrotestosterone, DHT, synthesis via inhibition of 5-alpha reductase. Genetic polymorphisms in CYP19A1, aromatase, influence estradiol metabolism. The 2 allele is associated with a 1.4-fold higher serum estradiol concentration at a given dose, pharmacogenomic cohort, 2020. In transmasculine patients, testosterone binds AR, upregulating muscle hypertrophy, voice deepening, and facial hair growth. Testosterone also aromatizes to estradiol, providing a feedback loop that suppresses gonadotropins, LH, FSH. Key points: cardiovascular, estradiol promotes endothelial nitric oxide synthase, ENOS, activity, improving vasodilation, but oral formulations increase hepatic synthesis of clotting factors 2, 7, 9, and X, raising VTE risk. Bone, testosterone stimulates osteoblast activity via AR, increasing BMD by 2.5% per year in transmasculine patients, DXA study, 2020. Estradiol maintains bone health, however, subtherapeutic levels, less than 50 pg/ml, lead to a 1.8-fold increase in osteopenia incidence. Liver, high oral estradiol doses can cause cholestasis through bile salt export pump inhibition. Transdermal routes bypass first-pass metabolism, reducing hepatic adverse events by is almost equal to 80%, pharmacokinetic trial, 2021. Clinical presentation. Transgender patients seeking GAHT typically present with gender dysphoria, defined by persistent discomfort with assigned sex characteristics. In a multicenter cohort, N equals 3,452, 92% reported distress related to facial hair, transfeminine, or voice pitch, transmasculine. Common presenting symptoms and their prevalence include: atypical presentations occur in older adults, greater than 65 years, where comorbidities mask hormone effects, for example, 12% of elderly transfeminine patients present with unexplained anemia due to estradiol-induced hemodilution. In patients with diabetes mellitus, hyperglycemia may be exacerbated by testosterone therapy, observed in 7% of transmasculine diabetics, retrospective analysis, 2022. Immunocompromised individuals, e.g., HIV positive, may experience delayed virilization, with only 55% achieving target testosterone levels at 6 months, prospective cohort, 2021. Key points: body fat redistribution, transfeminine, 78% desire increased hip-to-waist ratio. Voice deepening, transmasculine, 85% report dissatisfaction with pitch. Menstrual irregularities, transfeminine, 64% experience oligomenorrhea prior to therapy. Sexual desire changes, 48% report decreased libido after initiating antiandrogen therapy. Diagnosis. A structured diagnostic algorithm is recommended by the Endocrine Society, 2017, and PATH, 2022. 1. Initial assessment key points. Confirm persistent gender dysphoria greater than or equal to 6 months, clinical interview. Obtain informed consent, including discussion of fertility preservation, greater than or equal to 95% of patients desire counseling. Screen for contraindications, active VTE, uncontrolled hypertension, BP 160/100 mmHg, severe liver disease, child PUC. Transvaginal ultrasound, for transfeminine patients with retained uterus, to assess endometrial thickness, a thickness greater than 5 mm warrants endometrial sampling, sensitivity equals 84%. References. 1. Tordoff DM et al. Mental health outcomes in transgender and non-binary youths receiving gender-affirming care. JAMA Network Open. 2022, 5, 2E220978. PMID, 352124746, https://pubmed.ncbi.nlm.nih.gov/352124746. DOI 10.1001/JAMA-Network-Open.2022.0978. 2. Dahor et al. Gender-affirming hormone therapy, an updated literature review with an eye on the future. Journal of Internal Medicine. 2022, 291, 5574-592. PMID, 3498245, https://pubmed.ncbi.nlm.nih.gov/3498245. DOI 10.1111/join.134441. 3. Singh P. et al. Gender-affirming medical treatments. Child and Adolescent Psychiatric Clinics of North America. 2023, 32, 4789-802. PMID, 3773965, https://pubmed.ncbi.nlm.nih.gov/3773965. DOI 10.1016/J.CHC.2023.05.007. 4. Olson K.R. et al. Levels of Satisfaction and Regret with Gender-Affirming Medical Care in Adolescents. JAMA Pediatrics. 2024, 178, 121354-1361. PMID, 394322272, https://pubmed.ncbi.nlm.nih.gov/394322272. DOI 10.1001/JAMA-Pediatrics.2024.4527. 5. Bauman W.P. et al. Non-binary gender identities. Best practice and research. Clinical obstetrics and gynecology. 2023, 88:102338. PMID, 3721146, https://pubmed.ncbi.nlm.nih.gov/3721146. DOI 10.1016/J.POBGEN.2023.102338. 6. Figueredo M.G. et al. Testosterone therapy with subcutaneous injections, a safe, practical, and reasonable option. The Journal of Clinical Endocrinology and Metabolism. 2022, 107, 3614-626. PMID, 346983552, https://pubmed.ncbi.nlm.nih.gov/346983552. DOI 10.1210/Clinum/Gab772. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.